of Regeneractiva, and my main roles are to engage with the expert on the generation of scientific data and develop medical projects with key opinion leaders. If you think that I can help you in all of these matters, please, you feel free to contact me by email directly. And today I'm super excited to have you here and excited about the conversation we are going to have, because today we are going to talk about the differential diagnosis of diffuse alopecia. Diffuse alopecia is a condition characterized by a decrease in hair density all over the scalp. If you follow this, you will not only learn from the expert, but also you could ask questions directly to them through the chat box. I have to mention also that the presentation is being recorded and we could share with you and the request afterwards, and you will have 10 days to replay it again. And at the end of the webinar, a survey will pop up your screen, and we'll appreciate if you can complete it, because your questions and suggestions are very important to us in planning future events. We have divided the webinar in 3 main parts. First, we are going to talk about the differential diagnosis of diffuse alopecia. Later, our second speaker will share with us the results of a study that they are performing with our technology. And finally, we will have time for all your questions and comments. So today we have 2 great speakers that are going with us. So welcome, please, ladies and gentlemen, please welcome Dr. Antonella Tosti and Dr. Colombina Vincenzi. I hope you enjoy a lot and learn a lot.
Hello, good morning to everybody. And I'm going to share my screen as soon as Anna stops sharing her. Okay. And I'm discussing today the differential diagnosis of diffuse alopecia. So this is more on diagnosis than on treatment, but as you may understand, diagnosis is very, very important because we need to know what we treat. And diffuse alopecia may be a sign of many different diseases. So when we talk about diffuse hair loss, we have to think when we see a patient. And so we may have a patient with diffuse hair loss, like this patient who complains of very diffuse hair thinning, or you may have a patient like this that may look absolutely a normal density, but who complain of excessive shedding, because also the excessive shedding is often diffuse. And sometimes it's very difficult for us to understand if the shedding is normal or if it is increased. I think all of you are used to get these bags of hair that patients bring with them to show you that they are really shedding. And how do you understand if this is normal or abnormal? You know, of course, there are fluctuations even in normal person. And shedding is a volatile parameter. And of course, also depends on the hair density, because if 80 hair a day are the normal for somebody with a completely normal density, may be very high for somebody who already has a low density. So how can you distinguish? First of all, you have to do some test to understand if the shedding is really abnormal or not. And of course, you have to have a very careful history. You can use dermoscopy. We discussed that the last webinar. And sometimes you need the pathology. Let's discuss the pool test, which is very simple and doesn't require any special instrument. So you, as you see here, you grasp a tuft of hair at 2 centimeters from scalp emergency, and then you gently pull between the thumb and the index toward the distal tip. So when we have diffuse hair loss, you have to do the pull test in a different area of the scalp. When you have androgenetic alopecia, you have to do the pull test if you suspect androgenetic alopecia in the androgen-dependent scalp and in the occipital area. And when you have a patch alopecia, you have to do the pull test at the margin of the patch. So it's when is the pull test normal? When you extract less than 5 telogen hair, and I usually do the pull test on the same day of shampoo. There are a lot of many textbooks that tell don't the patients have to not shampoo before the pull test, but there is a very recent paper that really show that doesn't make a big change. Of course, it may be more positive if you don't shampoo, but even if you shampoo and you have a telogen effluvium, you have a positive pull test. And then you have to look at the roots under the microscope because you have, or under the dermatoscope, because you need to know if they are telogen roots or not, because that makes a big difference in the diagnosis. Here you see the different type of roots that you can see under the microscope. So this is a telogen root. You see the telogen sac, but this is a completely different root. This is a dystrophic anagen root. And this is an anagen root with sheaths. So you can see different types, and we're slowly distinguishing what they mean. So when you see telogen root, you should see telogen root in most cases of hair loss. You see dystrophic roots in anagen effluvium, so in alopecia areata, for instance, in chemotherapy alopecia. And you see anagen roots with sheaths. This is a very uncommon, okay? You see those in scarring alopecias, and especially lichen planopilaris, and you see those in pemphigus vulgaris. So these are very, very unique. And these are anagen roots without sheaths that are a marker of the loose anagen hair syndrome. All these conditions present as diffuse hair loss. So in androgenetic alopecia, you see excessive telogen roots or a positive pull test in the androgen-dependent scalp, okay? Because that's the androgenetic alopecia cause a shortening of the hair cycle, and so the pull test is usually positive in the androgen-dependent scalp. If it's positive all over the scalp, that means that androgenetic alopecia is associated with telogen effluvium, which may happen and, of course, change your treatment way. So androgen-dependent area is just androgenetic alopecia. In androgenetic alopecia in women may be very diffuse, so it's not uncommon to see positive pull test also in the parietal scalp and in the occipital scalp. Here you see a diffuse female pattern hair loss. So I see many of these patients with diffuse, especially young women, often present with this very diffuse pattern. As I already said, if the pull test is also positive in the occipital region, there is an associated telogen effluvium. So keep in mind that androgenetic alopecia and telogen effluvium are not always a differential diagnosis. They may go associated. And if it's associated, you have to target the treatment to address both problems. And telogen effluvium, of course, accelerates the progression of androgenetic alopecia, so needs to be addressed. So other possible situation in which you see too many telogen roots all over the scalp are acute telogen effluvium, chronic telogen effluvium, alopecia areata incognita, and short anagen syndrome. So acute telogen effluvium, usually the patient remembers the causative event, usually 3 months before the onset of the hair loss, and they have a very positive pool test. The hair density may be normal or reduced. When it's reduced, it means that the patient has lost at least 50% of the hair. Keep in mind that the COVID-associated acute telogen effluvium usually starts earlier than 3 months, usually starts after 2 months from the infection. So as an earlier onset. And many causes, drug infections, systemic disease, inflammatory scalp diseases. And keep in mind that scalp psoriasis or scalp contact dermatitis are a common cause of acute telogen effluvium. And you have always to rule out psoriasis when a patient presents to me with, acute telogen effluvium. I always look at the scalp with the dermatoscope to rule out psoriasis. I even may do a biopsy. Infections. And of course, it's the reversible. You see here how it was reversible in this patient without treatment, but may precipitate androgenetic alopecia. Chronic telogen effluvium is characterized by excessive shedding lasting for months of years. So they have usually a positive pool test, but not a very positive pool test. They have a normal hair density. In reality, these patients usually look as patients with a lot of hair. And even if the shedding persists for years, they don't develop hair thinning. So what I want you to understand well from this talk is that chronic telogen effluvium is not like chronic urticaria. It's not just a telogen effluvium that lasts for more than 3 months. It's a disease with specific characteristics. And often these patients are very distressed because they feel the doctors don't believe in them. Because if you look at the scalp, they look normal. And we don't know the cause, but we think that it's just a reduction in the duration of the anagen growth without miniaturization. What are the typical complaints of these patients? They complain that they shed a lot, their volume is much reduced, and often they have bitemporal thinning. So, as I said in the beginning, they have usually a only mild positive pool test. And these patients usually don't shampoo, so are more difficult to evaluate because they're afraid to shampoo because they associate shampooing with hair loss. And they bring bags of hair to show you that they are really shedding. And their fear is that they will be without hair. This patient collected all the hair in 3 months, and and that she even wanted transplant because she thinks she will be without hair in a few months. Loss of volume. Usually these patients have a very high density and have a good mass, and often they have curly hair. So they said that I have half of the hair I used to have, even if apparently they look normal. And the ponytail is a very important question. You always have to ask your patients. And they say, oh, my ponytail is 1/3 of what it used to be. And they have to keep cutting the tips to keep volume at the tips. And this is images for a patient of mine. So she went to the same hairdresser, and you can see that definitely the mass at the tip has definitely decreased. Because of course they shed, the hair regrow, but before the hair gets long, it takes time, and so the volume is lost. And they often have this bitemporal thinning. So don't misdiagnose this bitemporal thinning as androgen-dependent thinning. Is different. So dermoscopy, you don't see miniaturization, and you see normal regrowing hair of normal thickness. So at pathology, you don't see miniaturization. You have increased telogen, but you don't see miniaturization. So, of course, you need to exclude the possible causes of hair loss, including, for instance, systemic lupus. And it's very important to exclude early androgenetic alopecia. So, if this patient needs dermoscopy, and maybe you need to repeat the dermoscopy often because sometimes they develop androgenetic alopecia. Another disease that you have to consider is alopecia areata incognito. This is not common, but not very uncommon. It's a variety of alopecia areata characterized by acute and diffuse shedding on telogen roots, so it looks like telogen effluvium, and you can recognize by dermoscopy and by pathology. And usually as an acute onset may affect children and adults and cause diffuse thinning, severe, you see, as in these cases. Sometimes even sparing the white hair, which is a typical feature of alopecia areata. Some of these patients develop typical patches at the follow-up. You have a positive pull test with telogen roots. And at dermoscopy, you have the yellow dots, and you have, regrowing hair of normal thickness. Here you see another dermoscopy of this child, because you may see the condition in children. Then we have the short anagen syndrome. This is a disease that has been typically described in children, but may occur as well in adults. And here the complaint is different, is that the hair doesn't grow long. And you have increased shedding of telogen hair, and you make the diagnosis because all of those hair are short, less than 5 centimeters. So there is a synchronization of the hair cycle because the hair cycle is shortened, as for instance, in androgenetic alopecia, and so the hair doesn't grow long, and there is a kind of diffuse thinning. And sometimes may be localized, and you see that often in adults, they complain that the hairline has baby hair, as they call, and this is a variety of short anagen syndrome. Then, as we said, dystrophic roots are typical of anagen effluvium, and anagen effluvium you see in alopecia areata or in chemotherapy alopecia, and also radiation causes anagen effluvium. And here you see an example of a diffuse anagen effluvium from chemotherapy. Keep in mind that they often retain the hair in the occipital area, but the alopecia is usually very severe. Most patients shave, so you don't really see the alopecia because they don't bear to see all the hair falling out. And diffuse alopecia areata. This is remind you to always use your dermatoscope in cases of diffuse alopecia, because this is how you make this diagnosis. You see all the broken hair. So anagen roots with sheets. Anagen root with sheets and the pull tests are really abnormal. So as we said before, you see that just in scarring alopecia and in pemphigus vulgaris. Because in normal condition, the anagen hair are attached to the scalp. You cannot detach with a pull test. You can pluck with a trichogram, but you cannot take with a pull test. So in cicatricial alopecia, particularly lichen planopilaris, but also other cicatricial alopecia, you can extract anagen root with sheets, and this is a sign of activity. And here is an example of diffuse alopecia from pemphigus vulgaris, and pemphigus vulgaris also cause, loss of anagen hair with sheets. And then anagen roots without sheets. These are the marker of the loose anagen hair syndrome. And you see the loose anagen hair syndrome, that these patients have diffuse alopecia, and if you pluck their hair with a trichogram, they don't feel any pain, And if you look at this hair under the microscope, that you see the loose anagen hair. May not be seen at the pool test, always seen at the trichogram. And in this condition, the hair is not well attached to the follicle, so it's extracted with minimal force, so doesn't grow long. And they may have unruly hair, as in this case. And here you see the hair devoid of sheaths and ruffling of the cuticle, which is the typical sign of this condition. And you can see with a trichogram. Then it may be severe hair thinning without increased shedding. So you may see patients like this, they don't complain that there is increased shedding, they just have diffuse thinning, and this may be congenital or acquired. Look at this patient, for instance. He comes like this, and you take a look and you think, oh, it's androgenetic alopecia. But then you listen his history, and he says, yeah, I had completely normal hair until I had chemotherapy. And I have a picture of myself 1 year ago, you can look. And so this is very abnormal for androgenetic alopecia to develop in this severity in 1 year. This is permanent alopecia after chemotherapy, and you have to know this condition because it's not uncommon. And this occurs with several drugs, but the most important are busulfan, which is used in bone marrow transplantation, and this is a very common long-term complication in children surviving from leukemia. You see the diffuse hair loss. Another example. And it occurs with taxane chemotherapy, especially with docetaxel, when often involves not only the hair, but also eyelashes, eyebrows, and other hair, and may be very severe. So this patient present to you with this very diffuse thinning, but if you do a good clinical history, you find out the reason. So we don't know the prevalence of this permanent alopecia, can be misdiagnosed as androgenetic alopecia, as a kind of acute miniaturization and possibly caused by stem cell depletion. So this is the end of my talk, and I want to remind you about our next webinar, and which will be April 12 at the same time as today, and it's on treatment. So we'll be focused on treatment, and we have a special guest, Dr. Bonus from Thailand, who is a very a big expertise on combining the active regenerative treatment with hair transplantation. And so we'll discuss a lot of procedures such as the Regenera and the PRP and the difference between the two, because I know this is something that everybody always asks. So thank you very much for your attention, and I'm open to questions.
Okay, now is the turn of Dr. Colombina Vincenzi. I think that you are host now, Colombina.
Yes.
Perfect.
I'm here.
Yes, no worries.
Okay, I'm here.
Perfect. Thank you.
Thank you, Anna. So, just a second, I'm going to share. So, I'm going to show to you our experience with autologous micrograft technology. We performed a clinical study to evaluate the efficacy in improving hair density in patients affected by androgenetic alopecia. In this study, we enrolled 17 subjects, 10 males and 7 females, And the study lasted 6 months for assessing the endpoints, and we performed also, when possible, a follow-up at 1 year, after 1 year. Here you can see the inclusion criteria. We enrolled patients affected by mild androgenetic alopecia of Ludwig 1 and 2 for females, and Hamilton 1, 2, 3 vertex for males. All the subjects, of course, were willing to increase hair density and accepted to maintain hair length, color, and style for all the duration of the study, accepted not to start any other treatment for hair loss until the end of the study. And we excluded subjects affected by scarring alopecia, alopecia areata, or when were present inflammatory scalp disorders, or the subjects were on medication or affected by systemic disorders causing hair loss. We ruled out also pregnant females or breastfeeding, and excluded all subjects with an history of hair transplant or scalp tumors. And also we excluded from the study patients that did topical or systemic medication, or used medical devices or medical procedures for the treatment of androgenetic alopecia within 6 months prior to the study entry. How we evaluate the efficacy? We did at every visit a clinical evaluation. We performed standardized global photography. We performed video dermoscopy, and finally we used the Tricolab system provided by PhotoFinder. At each visit, we gave to all the subjects a satisfaction questionnaire to fill out. And we use to evaluate the change in hair density this 7-point scale. And instead, the Tricolab permitted to calculate hair density and hair thickness using dermoscopic images of the scalp without the need of hair shaving. And here you can see the results of the evaluation of the global photography. In 5 subjects, we didn't observe any change, and only in 1 subject was observed a slight decrease in hair density. Instead, in 11 subjects, we observed an increase, slight or moderate, in hair density. Here you can see an example. This is a 64-year-old lady who was very happy with the treatment, as you will see next video that where she answered to some question about her experience with regenerative treatment. As you can see, the hair density improved also in the frontal area and in the parietal area. Here you can see another example of improved hair density in an 18-year-old boy. Also him was very happy with the treatment. And another example again, where also the vertex showed an improved hair density. This is the satisfaction questionnaire we administered to each subject when we asked to all of them if they were happy with the results of the treatment. Most of them answered yes, they were very happy. And they experience a decrease, most of them also decreased hair shedding, and they described their hair stronger, with more volume, thicker and healthier after the treatment. And very important is that anybody experience negative side effects with the treatment. So we can say that the treatment was very well tolerated with any side effect. And what about the Tricolab evaluation? When we evaluated the results obtained with this software, we observed that after 3 months in the frontal region, there was an increase in the hair diameter by 7.35%, that was maintained after 6 months by 5.23%. Also in the vertex, there was an increase in hair diameter, but not so statistically significant as in the frontal region. Also after 6 months, the hair diameter was increased. So in conclusion, we can say that there was no effect on number of hair after the treatment as expected, but there was a statistically significant increase in diameter in the frontal area as well as in the vertex, even if not statistically significant. Thank you. I finished. Now I'm ready for the question together with Professor Tosti.
Thank you, Colombina. Thank you, Antonella, for your great talk. It was awesome, as always.
I cannot start my video, Anna.
Yes. Give us a second. Yeah, now Dr. Antonella Tosti is going to show you a testimonial of hers.
You know, I'm going to show you a video of the patient that Dr. Vincenzi showed you, the one with very good results. So like we get the video ready. He doesn't speak any English, so we have a translation because she could only speak Italian.
I think you should, yeah.
I'm ready.
Perfect.
Allora, signora, lei ha fatto il trattamento Regenera qui da noi. Mi dica la sua esperienza.
In che senso?
Secondo lei è stato efficace? È stato, ha avuto dei miglioramenti dopo il trattamento?
Sì, anzi continuano, credo. A me sembra di
continuare a vedere
sì, esatto, sì.
I nuovi capelli che crescono. Quando è che ha fatto il trattamento, signora?
Questo non me lo ricordo.
Circa
un anno, più di un anno forse. Poco più di un anno
fa. Sì. Bene. Durante l'intervento è stato doloroso, è stato interessante?
No, una cosa insomma tranquilla.
Dopo quanto tempo ha cominciato a vedere i primi risultati?
Dopo, secondo me, dopo 4-5 mesi. Sì, proprio che mi sentivo...
No, più che subito subito.
Infatti, io però invece l'ho sentito...
19 già dopo 4-5 mesi.
Io, cioè, proprio anche al tatto, cioè, capito? Più che visivo anche anche proprio al tatto, il capello, io ho cominciato a sentirlo diverso dopo 4-5 mesi.
Ha avuto qualche effetto collaterale?
No, assolutamente. Non ho mai sentito tensione, no? Anche dopo le punture, niente proprio, assolutamente.
Se dovesse dire qualcosa a qualcuno che vuole fare questo trattamento, che cosa le direbbe?
Di farlo, di farlo tranquillamente, perché innanzitutto appunto non ho sentito dolore, non per niente. Il trattamento non è doloroso e neanche successivamente. Quindi c'è proprio...
Grazie mille. Okay, so I think we finished the presentations and we are open to all your questions, because I know that often there are a lot of questions and we want to give you the time to answer all the questions that you have.
Yeah, if you want, I can read for you and
Thank
you
you.
both can answer. Okay. How is the prognosis of chronic telogen effluvium?
You know, this is a very, very important question, because that's something you have to make clear to the patient from the first day. It's called chronic because it's chronic. So it may last 20 years. So you have to tell the patient, this is a chronic condition. We are going to treat it, and we are going to, I'm going to tell you what I do. And but it's going to be chronic. So don't expect that you stop losing the hair. What I can tell you is that we have data showing that even after 20 years, you don't, your scalp will not be visible. So you will never develop alopecia. But they have to know it's going to be chronic. And don't see these patients every month, because, you know, usually these are patients I see every 6 months, because you cannot, of course, expect any fast improvement.
Okay, thank you. The next question is, how do you treat alopecia areata incognita?
Alopecia areata incognita. You know, I treat as alopecia areata. So usually I try to treat with topical. So I use often topical high potency steroids under occlusion. I use topical and oral minoxidil. I use sometimes systemic steroids. These are the main treatments. Of course, in very severe cases, you can think even, I don't know, I don't have big experience with JAK inhibitors in incognito.
Okay, perfect. Another question that we have is a case that she has a patient that she's 27 years old with hair fall since the age of 12. Now her hair is short and the eyebrow is less dense than what could be, than normal. What it could be? Wow, difficult.
Okay, first of all, could be androgenetic alopecia, because the androgenetic alopecia can start at pediatric age, and this is not so uncommon. And so that's a possibility. So you need really dermoscopy in this patient, because dermoscopy will rule out if there is miniaturization or not, which is the most important point. You know, other possibility is like short anagen syndrome. Sometimes they don't notice when they are children, they notice when they grow up. You know, that's another possibility. Eyebrows less dense, you know, this is only a sign of frontal fibrosing alopecia or of alopecia areata, but sometimes they say that and it's not really true. But again, you have to look and with the dermatoscope and see. If you don't have a dermatoscope, I would biopsy a patient like this.
Okay, thank you. Another question from Susanna Miniconi say, I had recently 3 patients with effluvium after Rocutan treatment. Persistence after 6 months after stop the treatment. Is this alopecia reversible?
you know, Accutane cause acute telogen effluvium. Acute telogen effluvium often unmask androgenetic alopecia. So if a patient with predisposed to androgenetic alopecia takes isotretinoin and gets telogen effluvium, this patient will have androgenetic alopecia after that telogen effluvium. So it is not reversible. So this is again a patient that needs trichoscopy and needs possibly treatment. When I start isotretinoin in patients with history of androgenetic alopecia, I always also start a treatment for androgenetic alopecia, because this is a very, very, very common cause of sudden development of androgenetic alopecia in young patients.
Perfect, thank you. The next one is, it is common to see broken hairs without yellow dots in alopecia areata incognita. Could broken hairs be a sign of other pathology manifesting as a diffuse hair loss?
You know, you can see broken hair may be a sign of other cause of anagen effluvium, like chemotherapy, alopecia, but you usually detect that from the history. Can be seen in trichotillomania, and trichotillomania is also may cause diffuse alopecia, but it's more often patchy, it's not completely diffuse. So possibly maybe if you have a patient like that, can possibly be alopecia areata incognita.
Okay, thank you. Oh, how many kinds of hair loss and disease are? Okay, another question from Dr. Panchapatre. And she asked, what is recommended treatment for permanent chemotherapy-induced alopecia? I only use oral minoxidil. Will PRP or Regenera helpful?
Hello, Bonus. Nice to have a question from you, and I'm so happy you are going to be with me in April. So I agree with you. Oral minoxidil is a good option for permanent chemotherapy alopecia, or also topical minoxidil. They improve, but they usually don't improve enough to be able to go out without a wig. So this is again something you have to discuss with the patient in order for them to understand that it is going to improve, but it's not going to be a cure. Unfortunately, they don't have enough hair left for Regenera, and also I don't think PRP is really useful in this patient. I do not recommend.
Perfect, thank you. Also, we have another question from Indonesia. He's a dermatologist resident, and he wants to ask about pemphigus vulgaris alopecia. It can happen in another kind of pemphigus or just pemphigus vulgaris. And why can alopecia in pemphigus patients?
So you can have also in pemphigus foliaceus another type of pemphigus, and of course the alopecia is due to the detachment of the hair due to the antibodies against the pemphigus antibody, the epithelium of the root sheath. And of course, if you do immunofluorescence on the hair that are that you get detached with the pull test, the immunofluorescence is positive. This is another way you can diagnose pemphigus vulgaris of the scalp.
Okay, thank you. And this is a question for Dr. Colombina Vincenzi. How long the result lasts in a patient, and when the results are visible after treatment for hair fall and hair density? Colombina, you are mute. You should unmute yourself. Now.
Okay, now I'm here. So we did the follow-up at 1 year, and all the patients were okay, but as we said a lot of time, maybe the treatment has to be repeated after 6 months. In our opinion, maybe the results will be more visible.
Okay, thank you.
I
Here
think there was another question. Just go back to that question. 1 second, Anna. Can you go back? Oh, you dismissed the question? Okay.
Sorry.
I think they were asking about density and...
yeah, I can find it.
Okay, so
yes.
Yes, we evaluated their density using the comparing the global photography and their loss using the questionnaire of the patients, and also we performed every time the pool test, but was not in the protocol.
Now, what I want to say, which I think is important, and sometimes people don't really understand well. So any treatment of androgenetic alopecia should increase the hair thickness. We don't expect to increase the hair density, because in androgenetic alopecia, the number of hair is basically the same, it's not reduced, it's the thickness that is reduced. So efficacy of treatment, I personally consider a treatment effective when it increases the hair thickness. I don't expect any treatment to increase the density. This may be just a transitory sign that that patient had telogen effluvium at the time of the beginning of the study. Okay, so it's very important that everybody understands that.
Yeah, and actually increasing the thickness, it increases the covering. So at the end is the result that the patient also want to see, right? Okay, thank you for all your comments. I have a question, it's in Italian.
I think Kobe can read, I translate the question.
Okay.
The question is that one patient in the study had a reduction in the global assessment. Okay, so why, and do you think you would repeat the treatment?
Yes, we can repeat the treatment, of course, and because that subject didn't come si dice?
It didn't improve, but it's normal, you know, not everybody.
Yes, not everybody has the same results with the same treatment.
Even with any treatment.
Yes, with any treatment.
Okay, thank you. The next question is, he want to ask about the microscope examination to help the diagnosis. There are any precautions on doing that, it? I mean, the hair we can choose for the examination from what area? Well, where is the area where you took the hairs for the examination? Or just keep searching for every hair that they have already lost?
No, usually, as I explained, in diffuse alopecia, you do the pool test in 5 areas of the scalp, okay? And when you have androgenetic alopecia, you do the pool test in the androgen-dependent area and non-androgen-dependent area. And in patch alopecia, you do the pool test at the periphery of the patch. So this is where you want to extract the hair. That's how you have to extract the hair. I never look at the hair that patients bring, because this is going to be crazy, except in case of scarring alopecia, because sometimes patients with scarring alopecia bring some hair because they say, I found some hair that look abnormal to me, and those I may look under the microscope to see if there is a anagen hair with sheath, or something that is a very typical finding in scarring alopecia, pili torti, okay? So that's the only situation. I just take a look under the microscope on the hair that the patient bring. Otherwise, how we evaluate those hair? we evaluate those hair by using the hair shedding scales. If you look, if you Google, I publish a paper on hair shedding scales, and you have visual images, and in this way you can establish if that amount of hair is a normal amount of hair that has been lost or is abnormal. But of course, you cannot count a ball of hair like that. So you have to consider and check, but you have to do what is possible to do.
Okay, thank you. Another question is, do you have good experience with oral melatonin for chronic telogen effluvium?
Hello, Sergio. Nice to see you here. You know, I prescribe oral melatonin in chronic telogen effluvium. Usually prescribe 3 milligram. You know, good experience is a difficult word. I like oral minoxidil more, but these patients are never really happy of the results of treatment. They keep complaining that they shed a lot.
Okay, thank you. Next question is, what is about beard hair improvement? Some doctors use stem cells procedures for the beard.
You know, depends on the disease of the bird, okay? Because this is a very important point. So there are some patients who have congenital sparseness of the bird. And I believe for those patients, there is no treatment that can really improve, and probably a transplant is the best option if for them the bird is so important. I have no experience on stem cell for the bird.
Okay. Also, we have another question that how Tricolab and PhotoFinder can be incorporated in the clinic for diagnosis?
You know, I use PhotoFinder for all my patients, okay? And I use Tricolab only for clinical studies, okay? But that depends on your expertise with dermoscopy. But I believe that with the PhotoFinder, you can take images of your patients, global images, and you can take dermoscopy. And so it's very important also, not just for the diagnosis, but it's very, very important for the follow-up. Because keep in mind that you cannot follow up hair patients without pictures. You have to have very good pictures, because these are patients that sometimes are very much improved and come back and they say that they didn't improve. So you have to show them the reality, because their reality may be not true. And so PhotoFinder is essential. And the Tricolab, you know, gives you measures. So it depends, it may be useful in androgenetic alopecia. Of course, for instance, you don't need a Tricolab for alopecia areata, for other type of hair loss.
Yeah, and if you need more information, please just contact any one of our team of Regeneractiva, and we will put in touch with people from PhotoFinder to help you with that. Okay, the next question is, will the response be good among female patients with female pattern baldness due to polycystic ovarium?
We don't have specific data. We didn't study a population of women with PCOS, but I think yes, because you know, female pattern baldness is associated with PCOS. It's not really due to PCOS. So I don't think. I think yes, there is no reason of not.
Okay. Now we have a patient saying that I started suffering from alopecia at age of 14 and I had drastic weight loss. Can it be reversed? I am 35 years old right now.
You know, it's the same as before. Weight loss cause telogen effluvium, and telogen effluvium unmask androgenetic alopecia. So this is androgenetic alopecia triggered by telogen effluvium. So it can be reversed with treatment of androgenetic alopecia, cannot be reversed without treatment. And I saw a question you skip, and I think it's important. Will Regenera be effective on white hair, old persons?
No, I didn't pay. So I didn't pay. Yes, yeah, well, we can answer that.
I think
Yes.
this is a
Sorry.
very important question.
Yes, super.
Why? Because yes, and our testimonial had the white hair. So this is important because it means that age is not a restriction.
Okay. Yeah, super important. Thank you. Another, for androgenetic alopecia, how often would Regenera have to be conducted for satisfactory results? And if there is any studies on difference in response results of Regenera for Caucasians, Asians, and Africans or Americans?
You know, I believe that we don't have the answer for those two questions, are very good questions, and that's what we need to understand for the future. You know, I don't think we have, at least I don't know the answer. I don't know if Anna has some information more than I have.
No, regarding the studies, we don't have any comparative studies, but because we have doctors from all over the world doing our procedure, we have seen good results also in any type, like Caucasians, Asians, and Americans. I think we have also people from Africa, and they have also good results. So I think it doesn't matter from where you're from, that it works. Colomina, you want to add something?
You're mute.
Yes, I know. The same. I think that is maybe effective in every ethnicity. I don't think that there is a difference.
Yeah, we haven't seen any difference. Yeah. Okay, next question. If we have already have trichoscopy, should we do measurements like Tricolab does for diagnosis of androgenetic alopecia from 3 different areas, not only for the I think that she refers that if it's necessary to do Tricolab for the diagnosis of androgenetic alopecia.
You know, I do Tricolab only for studies. So you have to distinguish what a study when you want to see if the treatment increase the thickness, or normal life, okay? Normal life, I usually don't take these measures. I just do a global photography and dermoscopy, but we can always take measure using, there is a program in the photo finder where you can measure, if you want, the thickness of the hair. But I don't do in normal life. Otherwise, you spend 1 hour for patient, and it's not really so important. This is something very important for a study.
Yeah, well, we normally recommend to use a photo finder if you are not super well used to do this kind of diagnosis in order to rule out the other kinds of alopecia, because as you could see, as Dr. Tosti has shown today, there are so many types of hair loss and alopecia, and if you are not super well known, you don't know.
But not the Tricolab, okay? The Tricolab is not helpful at all for differential diagnosis. The Tricolab, it's just measure the thickness. So for the differential diagnosis, trichoscopy, so the photo finder is very important together with the clinical history, with everything. Because if you just do that, if you just take the dermoscopy and don't listen to the patient, don't take a good history, you can miss it. You don't do the pool test, everything is important. It's like for any medical diagnosis. So, and the Tricolab is just useful in androgenetic alopecia. So you need to have a diagnosis before doing the Tricolab.
Okay. Thank you. Another, can short anagen syndrome start any time of life?
No, usually the short anagen syndrome starts in childhood. So you have from birth. But sometimes patients can notice the problem later on, which is different because maybe it was used to, there are children that the mother always keep the hair short. So they don't notice the problem until they decide to grow the hair long.
Yeah, okay, thank you. Does Regeneractiva help with reversing alopecia?
Reversing alopecia, Regeneractiva helps in increasing the thickness of the hair. And if the hair gets thicker, cover better the scalp. So it's not reversing, it's treating, okay?
Okay. Does telogen effluvium start androgenetic alopecia, or was it already present?
Telogen effluvium starts androgenetic alopecia in some cases, but in most cases that patient already had minimal androgenetic alopecia, which was undetectable because early androgenetic alopecia is maybe not seen without checking with the dermatoscope, and the telogen effluvium cause the shedding of a lot of hair, all the new hair grow back thin, and so becomes visible.
Okay. How many times can we repeat the AMT protocol?
You know, again, I think we can repeat several times, but we don't have the data. You know, there are no data on that. It's a new treatment. There are no such type of data.
Okay, another question is, I have a patient with frontal fibrosal alopecia, treating her with dutasteride, topic minoxidil, and sometimes steroids depending on the activity of the disease. But she is not going as I would like to. I don't have oral minoxidil. Well, I don't know the question.
So the question is what to do. Okay, first of all, I don't like topical steroids in frontal fibrosing alopecia because these patients already have a lot of atrophy of the skin. So I like much more tacrolimus as a topical treatment. Then, you know, you can consider using anti-inflammatory like Plaquenil. You can consider using low dose naltrexone. You can consider even using tofacitinib. So there are, you know, like second stage treatment. And if you see still activity and if you see the disease is progressing, I believe you have to add something. It means that the dutasteride is not enough.
Perfect. Another, after you perform Regenera on your AG patients, while waiting to do the results, do you still give them minoxidil from home care?
You know, the patients from the study just had the Regenera because that was the
Yes.
study. But in a normal life, of course, I treat
You
the
can give minoxidil, of course, yes.
I treat the patient with minoxidil, with finasteride, with all the treatments that I normally use and add the procedure.
Yes.
Okay. Another question is, from all the conditions that has been presented, which will be the best treated with Regeneractiva?
The data that we have are mostly on androgenetic alopecia. Of course, you have to keep in mind if you have a very diffuse alopecia like chemotherapy alopecia, or you don't have even the area to take the graft to do the treatment, you know, because the basis of this treatment, you have to have a good donor area to get the progenitor cells from that donor area. If the patient has a very diffuse alopecia, I don't expect to see results because there is not the science behind to believe that we can have results. So of course you have to select depending on the clinical situation. Anna, you're mute.
Sorry. Now, another question is how to prevent progress of white hair in young age?
Okay, I think if I know that, I will be ultra rich.
Okay. I was curious for this. I asked.
What I do, I just give them antioxidants, and that's it, you know, but I don't have the answer to this question.
Okay, another question. Does Dr. Tosti use regenerative treatment? Yes.
Yes, I do.
Okay. I think there are.
I have a few other I see here. What
Okay.
is experience with squaric acid in alopecia patients? So squaric SADBE is squaric acid dibutyl ester. This is a good treatment for alopecia areata. You know, I believe that 40% of patients respond to this treatment, and is good because it's safe and is easy to do even in children. So I have a good experience. Loss of eyebrows of only one side. Oh, this is interesting. Okay, the loss of eyebrows only one side. I would think alopecia areata. I would think maybe frontal fibrosing alopecia. The beginning, maybe only one side. Lateral side of the eyebrows, maybe syphilis. Okay, but should usually symmetrical. Another disease that causes loss of eyebrows is keratosis follicularis spinulosa decalvans, and that's also to be considered. You know, sometimes hair shaft disorders. You know, maybe some hair shaft disorders may be only confined to the eyebrows. So that's a big differential diagnosis. You have to use dermoscopy and have a very good clinical history. And then I see, can Regenera treat anagen effluvium? And anagen effluvium is reversible by itself, you know, and I don't think Regenera can be considered in alopecia areata. It's a completely different situation. So the answer here is no, I wouldn't suggest Regenera for anagen effluvium.
Okay. I think that there are most of the of the questions. So finally we came to the end. So I would like to thank you again, the speakers, for the great, informative, and super interesting talk, and for all of the audience for your active participation. Hopefully, the presentation was beneficial for everybody. But before we leave, let me show you all our next webinars. Now in February the 19th, we will have a new application of AMT protocol with Dr. Perego and Dr. Aisegul, because we are going to talk about face treatment. Later, on 26, we are going to have 2 online trainings. They are focused for new users or people who are interested to know how to do the procedure. And you can bring your own patient and we can follow you and make your suggestions. In March, we will have the 18th of March, a fantastic webinar too with Dr. Jerry Cooley and Dr. Panchapatrep that are going to talk about the combination of hair transplant and Regenerativa. And on 26, we will have another online training. And in April, we can count again with Dr. Tosti and Dr. Panchapatrep to talk about what's new in the treatment of alopecia and androgenetic alopecia. So thank you everybody for your time, and please remember to fill the survey to help us, and hope to see you soon. Thank you.
Bye-bye, everybody. Thank you.
Bye-bye.
Bye.
Bye.
¿Qué tengo que hacer? All the links for the next webinars you will find in our Instagram account. So no worries, we will inform you by newsletter or by communications through the Instagram. Okay, thank you everybody for coming today.
Редженера – будущее регенеративной медицины. Лечение андрогенетической аллопеции с помощью метода Редженера. Выполняется разметка в гормононезависимой зоне с наибольшим количеством волос фолликулярной единицы. В зависимости от выраженности и распространения процесса на волосистой части головы производится забор от 1 до 4 биоптатов размером 2-2,5 мм. Далее выполняется местная анестезия раствором 2% лидокаина, без добавления сосудосуживающих препаратов. Анестезия производится перпендикулярно и по периферии намеченной разметки. Производится забор биоматериала пациента с помощью панч-биопсии 2-2,5 мм в диаметре и глубиной 7 мм. За счет минимального размера после забора биоптата не требуется наложение швов. Благодаря оптимальной запатентованной системе, состоящей из 100 микропирамидальных отверстий и круглого ножа, производится данная дезагрегация ткани. После обработки к биоматериалу добавляется стерильный физиологический раствор. Полученный биоматериал помещается в запатентованную систему картридж Regenera Cons, где в течение всего 1 минуты будет произведена механическая дезагрегация тканей до размера 50 микрон. Картридж устанавливается в аппарат Regenera, где производится обработка биоптата. Процедура проводится в стерильных условиях. Полученная суспензия вводится в зоны, подверженные андрогенетической аллопеции, которые мы хотели бы регенерировать. Техника применяется по аналогии мезотерапии с созданием папул на расстоянии полсантиметра. Мы используем тонкую иглу 30G, что уменьшает болезненность процедуры. После лечения пациент может вернуться к своему обычному образу жизни. Голову можно помыть через 2 часа. В течение 24 часов не рекомендуется посещение саун, бассейна и физические нагрузки. Контроли после процедуры производятся через 1, 3 и 6 месяцев. Процедура выполняется амбулаторно всего за 1 час в размере одной сессии. Процедура Regeneron не требует повторений.